Wonderful. That was a very nice case that my partner, Dr. Lee, performed and actually highlighted the issue of thrombosis. Chris, I want to go quickly to you, Dr. White. At the end, June mentioned the fact that not covering the ostium of the SFA. You know, when I was training, we always try to shy away from covering the profunda or extending stents into the common femoral artery. And I was burned early on in my career with the same mistake that June kind of made in this case by trying to preserve the not stenting into the common femoral. Your thoughts, you know, what's the teaching point related to that?
Well, the teaching point is he had stent thrombosis because he had flow limiting dissection. He had flow. He had something that limited his flow. And I agree that if you can avoid the profunda, you're not sloppy about throwing stents into the ostium or the SFA. But by the same token, if you want it to work, you need to restore that flow. And so I don't know that there's a role for anticoagulation. Even if there's impaired flow, anticoagulation won't work. So you really do. And again, when using some of the larger stents that we place, the peripheral stents, we still gain access to the profunda. We are not jailing a profunda that you can't gain access to if you need to with the peripheral stents. So I wouldn't hesitate to cover a profunda if I need to.
Thanks. Dr. Sai, we have so many equipments now in our armamentarium. Classically, when we had a patient with acute limb, we put a catheter, we lyse the patient. Now we have penumbra, we have angiojet, we have other technologies that are available to us. How do you decide when you should lyse the patient, or when, in this case, like Dr. Lee performed, do angiojet or do penumbra or do suction catheter or other form of therapy? And when do you combine the two? You're mute, I'm sorry.
Yes, there we go. Okay, I think that's a good question. The classic teaching regarding lysis is it depends on how acutely ischemic the leg is, because lysis generally takes 24, 48 hours. So oftentimes, if someone has acute thrombosis, they may be for lysis, but you often have to open a channel, right, before you can lyse them. So we'll do a combination of angiojet on the power pulse mode, and then leave a lysis catheter to try to open up the outflow. But I think ultimately, regarding the thrombectomy devices, it's sort of what you are most comfortable with, and that will probably work best in your own hands. But I think this was a very difficult case, and I think we've all had this happen. I had one where I didn't fix the ostium of the SFA, and the stent went down in the PACU, and I took him right back. And then I stented into the common femoral. And then a year later, I went back and did a bypass and took out the stent in the common femoral artery. So I think we've all done it. And we always try to avoid the, stenting it over the profunda. But, sometimes the groin cut down is not a bad thing. And then you open up the profunda again and they're okay.
Thank you. Mazen, when do you put a filter in these cases? If you decide to go the mechanical route, how often do you put a filter, and give us some guidance in regards to the landing zone of the filter?
Yeah, I try, if there's not a very good runoff or if the thrombus burden is really very big, try to put a filter. It does help at times, try to put it, of course, proximal to the trifurcation, distal popliteal or distal SFA, depending how far down the thrombus goes. I usually go with an 014 wire and a bigger catheter, try to inject distally, see where the thrombus ends, can make a decision about the filter. Unfortunately, I've seen the filters get overwhelmed when the amount of thrombus is too much, but it still will help you, not to get all the distal embolization. If you want, you can put another wire inside the filter and take your suction catheter, whatever you're using, all the way down and try to clean the filter if needed. So it will be important, especially if there's not a lot of good distal runoff.
Yes, and I'm going to ask one more question and try to catch up with the time from Dr. Sesemski. Eric, we June discussed the Eliquis. Obviously, we have Compass, we have Voyager. Has that changed your practice? And do you agree that in patients like this that are coming with, although there was a mechanical issue, what is your threshold in regards to moving to the Compass kind of a Voyager kind of a model?
Great question, Mehdi. I think really relevant right now. Voyager data is really convincing that there is a role for Xarelto 2.5 twice a day as an adjunct after peripheral intervention, and it's both endo and bypass. I think, as Chris said, is totally right. You have to solve the mechanical issue first. It's not going to do anything if there's a residual mechanical issue. But the acute limb data from Voyager is pretty convincing that there is a role for Xarelto 2.5. I think we're still figuring out what's the right therapy in the immediate time after a peripheral endovascular intervention, whether we should bail on Plavix and use Xarelto, use all three with aspirin, or stick to just aspirin Plavix. But if there's a concern about residual, issue that might cause a thrombosis, whether in bypass or endovascular, I think adding 2.5 BID of Xarelto is safe and a good option. And it's not right away at the first month follow-up. Is my current protocol right now is to switch off Plavix and go on to Xarelto.